Good evening, everybody, and welcome to our Thursday weekly University of Miami Cerebrovascular and Skull-Based Symposium. This is our number 10. Welcome. I'm Heros-Morcos, professor and co-chair of the department here and director of Cerebrovascular and Skull-Base. And as always, every week, I am always delighted to have as co-directors on this course, Carolina Benjamin, assistant professor here in our department, specializing in brain tumor and skull-based surgery, director of our cadaveric Keynes lab, and also head of our Jackson North neurosurgical service, as well as Michael Ivan, assistant professor and director of research at UM Brain Tumor Initiative, specializing in brain tumor, skull-base, and epilepsy surgery, as well as my two endovascular, open vascular colleagues, Bobby Stark and Eric Peterson, who run our endovascular service. Of course, most of you by now know Miami, our beautiful city. These are our two main hospitals, UMH and JMH. We, of course, are a tertiary or sometimes quaternary referral center, a very busy place with not just CV and skull-based cases, but all kinds of neurosurgical disciplines committed to clinical and research initiatives. This was the start of our weekly Thursday program. The link at the top is what will what will take you to all our educational programs. Welcome to use it. We are now down here, session 10, and you can see on our website what also is in the pipeline. And we probably will continue into October and November to build more sessions for education. So a teaser for next Thursday will be also a debate format, like today is a kind of a debate format on skull-base, anterior skull-base meningioma. We'll have Danny Prevedello defending the endonasal endoscopic approach, and Henry Schroeder defending the transcranial approach, with our excellent panelists, Ian Dunn, Gerardo Quinto, Madison Michael, and Ted Schwartz. Please join us if you are interested in skull-base. Now, as you know, on Wednesdays, Mike Ivan, my partner, has been running a very successful Miami Global Brain Tumor Symposium, and he must be up to number 13 or 14 by now. And next week, we're delighted that he managed to invite Luigi Cavallo to talk about endonasal endoscopic approaches for craniopharyngiomas, pituitary adenomas. So you get a double header next week, Wednesday and Thursday, on excellent skull-based topics. These meetings are not possible without the help of Ingrid, Roberto, Christina, and particularly Ignacio, who runs our weekly webinar here. And I again thank them, as I do every week, for their invaluable assistance in doing this. Again, I encourage you to visit that website on our neurosurgical department site. You can see all the things you need to see. You can contact me. You can contact Ingrid Menendez or our departmental Instagram and departmental Twitter, or my personal Twitter if you wish. Housekeeping instructions for tonight. Please, audience, put your questions in the Q&A box. I promise you we will get to most of them, at least, if not all of them, by the end of the session. I know that's the most important part of the evening for you, probably. We do not offer CMEs. If you like these sessions, share the links with your colleagues on social media. I will remind our two main speakers about 2 minutes before their 25 minutes, that 25 minutes is coming close. Now I'd like to introduce our wonderful panelists. First, Stefan Munich, who is assistant professor at Rush University in Chicago. Stefan, I was very lucky to have him as a fellow a few years ago, and he's gone on to doing fantastic things in endovascular, open vascular, skull base. And so he's got that equanimous view of the whole topic, and I'm delighted he's joining us and to show us what his thoughts are on AVMs and whether EMBO helps or not. Jeremiah Johnson, I was a resident here at the University of Miami. He's now assistant professor of neurosurgery at Baylor College of Medicine in Houston, also duly trained endovascular, open vascular, did a fellowship with Gary Steinberg before going on to start a fantastic career in vascular and also skull base surgery. And again, thank you, Jeremiah, for joining us tonight. Now, the award of the evening for thanks has to go to Atul Goel. I don't think Atul needs an introduction, but he is my friend for more than 30 years now. And Atul, of course, is professor and head of neurosurgery at King Edward Memorial Hospital in Mumbai. And he is in Mumbai right now, awake in the middle of the night. I think it's 2:30 or 3 a.m. just to participate with us here in this meeting. Atul is a prolific writer, hundreds of published papers, has done it all, open vascular, skull base, has some of the largest series in various pathologies in vascular and skull base. Atul always has a very strong opinion about things, and I have no doubt this will come out tonight. I have known him since the late 80s when we intersected in London when we were both with Alain Crocard, and we've had a lifelong long-distance friendship. Last but not least, Roberto Heros. I guess I would describe him as my big brother in neurosurgery. I was his resident many moons ago in Minnesota, again, early 90s. We've been partners since 1995 here at the University of Miami. If I've liked cerebrovascular, is because of Roberto, a master cerebrovascular surgeon who has seen it all and also is a spectacular critiquer of the literature and of colleagues, because he does call it the way it is, and his honesty is unequaled anywhere. And of course, he has vast experience with AVM surgery, and I'm delighted Roberto is with us to complete this panel. So the two speakers, let me start with Adam Arthur, professor of neurosurgery, chief of division of vascular neurosurgery, University of Tennessee Health Science Center at the Semmes Murphy Clinic in Memphis. Adam is a native of Western Virginia from the Shenandoah Valley, went to college and his MD in '98 at UVA with Neil Cassell. No, I'm sorry, not with Neil Cassell. He did 2 years with Neil Cassell between college and medical school, did work on aneurysm and vasospasm. Undoubtedly, that must have created his love for vascular, did his residency and his MPH at University of Utah under Bill Caldwell, then did his fellowship in both open and endovascular in Memphis and has been there ever since. Besides loving snowboarding and racquetballing, Adam is certainly one of the brightest people I personally know, and I do know a lot of people. And Adam is just one of those very thoughtful, masterful in everything he does, was a past president of SNES, will be running the scientific program committee of AANS, many other commitments. I'm not going to waste people's time talking about, but his opinion is always very well thought out, and he tries to keep a balance, I think, between open and endovascular, and that's one of the main reasons he is here today, to really tell us what he thinks about AVMs. And after that is Mustafa Baskaya, who's now Robert Dempsey Professor in Neurosurgery, Director of Skull Base Surgery, Program Director of Microsurgery, Neuroanatomy Skill Lab at the University of Wisconsin in Madison. Mustafa was born in Turkey, got his MD in Ankara University. You can see the picture of his university in the top left. Did his pre-residency fellowship, post-residency fellowship, his residency here with us, University of Miami. And both Roberto and I clearly recognized greatness when we saw it. Now, he also, as a passionate student of neurosurgery, has been to Nagoya University on a Sugita fellowship. You can see a picture of Sugita there, was with Anil Nanda, LSU Shreveport, and of course was here. With sports, he loves soccer, and I love Mustafa. Mustafa is, there are many ways to describe him, but I think this little formula at the bottom is a good summary. Mixture of passion, incredible focus, dedication, but above all, humility. You do that all together, and you are also a master surgeon, and that's why he's beloved by his patients. You can see him, I think, carrying one of his patients there. You can see his love in education. He's got a spectacular lab where he inspires his residents to love open, vascular, and skull base. And of course, as he probably will tell you, he's been heavily inspired by my big brother, Roberto Heros, in his practice as well. And I've spoken too much, and I'm going to shut up right now. I'm going to ask Adam, please share your screen, unmute your microphone, and go ahead with your 25-minute presentation.
Thanks, Jacques. I hope you guys can hear me okay. I'm looking forward to this debate.
Yes, we can.
Fantastic. So in the tradition of Jacques Morcos, one of the things that he's famous for doing is going after his opponents. So my opponent tonight is Mustafa Baskaya, who you can see here in his Twitter picture. I'm not going to go into his health grades reviews, which I know Jacques done before. I'm not going to mix up his name, but I will point out that he's clearly a very sinister character. He's brilliant. Jacques and I can agree on that. He is supported by an army of helpers. I have one of his ex-residents as a partner and another coming as a fellow next year. And he's certainly going to dazzle you with his skillful and deceptive presentation. So with that said, I think you can see that there's a very famous character that was based on him, and that's Gru from Despicable Me. The resemblance is absolutely remarkable. As far as AVMs, I'm going to start with a little background. There are a lot of controversies in AVMs. Luckily, we don't have to talk about all of them. But these are all areas that learned people can argue about. Tonight, we're really only going to be talking about what, if any, role there is for embolization before surgical resection of AVMs. In order to make that argument, I really want to go over my philosophy for AVMs and the evidence we have. So to establish that context, I'm going to review the most important part of any surgery, which is the patient selection, what we have in the scientific literature, because we are physician scientists, and then recommendations on approach, and a little bit more about embolization than we usually have, since that's my role tonight. So AVMs are complicated and they're unique. This is an illustrative case that was put together by an ex-fellow, Tarek Abuelam. It's a young man, 26 years old, who presents with this hemorrhage. Here you can see both sagittal and coronal views, selected angiographic views showing the supply from the posterior cerebral artery predominantly, with a few different branches. So as a way of encapsulating some of the literature on AVMs, we can talk about the various factors that might lead you to make a decision in any one given AVM. Comorbidities affect the natural history and surgery. Age affect both, but in opposite ways. A younger patient has a greater cumulative risk, but enhanced ability to recover from surgery. Obviously, rupture increases the risk of natural history and decreases the surgical risk. Diffuseness increases the risk with intervention because of intervening brain and the plethora of more supply. And then size increases the risk both in natural history and in surgery, but it seems to be that size is probably not a natural history risk, maybe more of a presentation bias issue. And then exclusively deep venous drainage portends a worse natural history and obviously increases the risk with surgery. Location, infranatorial versus supranatorial, eloquent versus non-eloquent, depth, cortical versus deep, and then shunting. There's an increased risk of bleeding with higher shunts and an increased risk with natural history. There are different ways to group these factors. If you look at these three factors, these are the factors that Neil Martin and Robert Spetzler pointed to in their Spetzler-Martin grading scale, indicating that worsening size, deep venous drainage, and eloquent location increase the risk with surgery. And then these factors are present in Michael Lawton's supplementary grading scale, which I find very useful in looking at AVMs and making treatment decisions. These factors, in terms of the risk of rupture, are concordant. In other words, they modify the natural history and surgery in the same direction. And these factors are discordant. A younger patient is easier and safer with surgery, but has a greater natural history risk, whereas a ruptured patient has a worse natural history risk and an easier surgery. So when you look at an AVM and you consider the possibility of treating through any modality, I'm going to get to embolization and its role, you have to look at that annual risk after the hemorrhage, symbolized here by the lightning bolt, and the cumulative risk that you see over the course of a patient's lifetime. And what Spetzler and Martin pointed out is that in different classes, grade 4 or 5 AVMs, grade 3 AVMs, or grade 1, 2 AVMs, you're going to see a different area under the curve. And this sort of calculus really guides an experienced physician in making recommendations about whether an AVM should be treated or not. Indeed, Spetzler himself has indicated that a simpler 3-tiered grading scale makes more sense in retrospect. In terms of the principles of surgical dissection, there are a lot of things we look at. Let's remember this 26-year-old and think about his blood supply. A surgeon will analyze this blood supply and analyze the different planes that must be dissected to get this AVM out, as well as the arteries that go to feed the AVM, in this case, the PCA branches, and the isolation of the nidus from the vein and the surrounding brain, as well as the ventricle. On the lateral, you're going to see the same picture. And again, good surgical knowledge means reconstructing a 3-dimensional picture from the data that we have and thinking about those planes of access as you go in to remove this with circumferential dissection. So this is that patient. This is that AVM. And the approach you take is really to make a very large flap, position yourself very carefully, and make sure that you're taking care of yourself and can operate from a good position, managing fatigue. It's also very important to have the right tools. The importance of bipolars, microclips, retractors when necessary. And this is really an operation that requires good assistance, if not co-surgery. I know that many surgeons believe in the chair and mouthpiece. We often will tackle an AVM with 2 surgeons head to head. I think both have their advantages. And then although you think of an AVM as a geographical spot, it really isn't. It's a disease of the brain that requires dissection to detach it and prune it away from the brain before getting to the vein. We have many experienced surgeons here. They can tell you better about how to avoid trouble, but as someone who's been in trouble with an AVM, I can tell you, you don't ever want to get there again. So you begin to develop a fear and a respect for these lesions after a few bad experiences. If you do get in trouble, you really need to force yourself to relax, focus on the arterial input, use clips and cotton, and know when to change your attack. Michael Lawton calls it when an AVM gets wild, and the need to get it out. So I'm going to briefly review the literature because I think that's important. The Spetzler-Martin grading scale, as I mentioned, was published in 1986, and the supplementary scale, which I really think is a great contribution, was published just 10 years in 2010. The foundation for radiosurgery is remarkably shallow. a retrospective review of 531 consecutive patients published in the New England Journal of Medicine here, but there really isn't good randomized control evidence indicating that. And then similarly, I don't think the evidence in the literature for embolization is strong. The randomized evidence consists of this approval trial, which shows that Onyx is not worse than NBCA. And then most of the argument for embolization, increasingly recently as a standalone treatment, which isn't our topic tonight, consists of single center self-adjudicated case series, of which there are a plethora in the management of AVMs. Unfortunately, the biggest randomized trial we have is Aruba, and although it's very familiar to everyone here, I will go briefly over this trial because while it's been widely lambasted, I think there are some good lessons to be learned. Basically, the plan was to follow AVMs managed either conservatively or intervened upon in whatever way the treating team wanted to do, which I think is one of the major problems with the trial, but it was ended early following a pre-planned interim analysis. Here are the characteristics of the AVMs. As you can see, most of them were relatively small and some had associated aneurysms. Most were relatively low grade. And here's the Kaplan-Meier curve, which really represents the primary outcome of Aruba. The point that I think must be made about Aruba is that the single greatest treatment pathway among the AVMs treated were standalone embolization. Again, a therapy that has not been validated except in single center self-adjudicated case series. And almost none of the AVMs in Aruba were treated with microsurgery or even with embolization and microsurgery. So it's not a trial that pertains to what we're talking about today, but it does show us fantastic natural history data indicating that there's a rupture rate of about 3 to 4% per year, a stroke death rate of about 11% at 33 months. The early reduction, the short follow-up, together with the lack of stratification or definition of treatment, means that recently, with the 5-year results, we're still seeing results that indicate that medical management is quote unquote superior, which I really think does the intervention, particularly surgery for AVMs, a great injustice. And then the last thing I want to say about the literature is we do see recent indications that despite the lessons of Aruba, more unruptured AVMs are being treated aggressively by physicians in the United States and elsewhere. And much of that aggression is on the endovascular side without, in my opinion, very good or logical basis for this. This is a recent paper, very recent paper out of the Mayo Clinic. So we see in the science a lot of self-adjudicated case series, and we see very little study of a careful, judicious approach to AVM surgery. So let me briefly talk about embolization before going over a few cases and making the argument that I must make tonight. NBCA was the first agent. It's essentially superglue. It's exothermic and very adhesive. It causes necrosis. It's an immediate endothelial stripping response. It's quite hard when you remove it surgically. Ethylvinyl copolymer was originally designed as a food preservative. It is cohesive, and it more sticks in the artery and expands the artery. It's become, I think, a much more preferred embolisate than NBCA. There are a few others that are DMSO based. That DMSO can cause its own damage, and ethylvinyl copolymer really fills the vascular space. So let me show you a few examples where we've used largely ethylvinyl copolymer or Onyx to good effect. The first is a 25-year-old grad student who has expressive aphasia while he was in the shower. He presents with this hemorrhage. No impending terrible mass effect, but still an AVM that's in an important place for a graduate student. He received a single embolization at about 3 to 4 days after presentation, and then he went immediately to the operating room. You can see that in this case, the embolization largely filled this relatively small AVM without extending into arteries or veins in any way. The AVM was resected safely. Here you can see a little bit of the operative video resecting the AVM. And he was able to go home with outpatient speech therapy. Now, in this case, Could you have treated this AVM without embolization? Absolutely. But at our center, we find that a dense AVM with a heavy shunt like that can be made much safer through a judicious, careful embolization as a part of the therapy. So here's a case where we used embolization really to fill the lesion itself in a uniform fashion as a immediate standalone embolization prior to surgery. Not standalone, but one session. Here's a different way of using an embolization. This is a 58-year-old who works in one of our hospitals, has an AVM that's known about since childhood, but goes down syncopal with no warning at the age of 58. And unfortunately, his intracranial pressure matched his age. So here's this very large AVM, casting of the ventricles, some mass effect, and at an ICP of 60, I was concerned that an immediate evacuation of the AVM would likely result in catastrophe. In fact, I really didn't even want to do a craniectomy. So what we did in this case was a very rapid embolization to reduce shunting. The superior embolization carried out through the MCA branches is not to make surgery easier, it's to dramatically lower the throughput of the AVM. And then the deeper embolization through the PCA feeder, in contrary, is to both reduce shunting and to make surgery easier. So this was accomplished rapidly. His ICP was brought under control with medical therapy. And then at a later date, we're able to go to the operating room with 2 rested surgeons and take out this formidable AVM in a more civilized fashion at a time when you're a better surgeon. This is a way of using embolization to make surgery safer. And I think that use of embolization makes sense, is rational, and should be offered at the best medical centers that we have. I'm going to show you 2 more cases quickly. Here's a young woman, 34-year-old, with a questionable history of perhaps seizure and an AVM carefully studied with DSA. Again, this is a small AVM. Could this AVM be taken out without embolization? Why, yes, of course, it could. But is there a rationale for treating this with embolization as a part? This woman's ACA is probably the size of my carotid artery. It's massively hypertrophied, and treating this AVM is going to require extensive dissection in a scarred subarachnoid space in the interhemispheric fissure, which is where the only venous drainage is. And sometimes those veins are quite stuck to the dura and to the sinus. So in this case, we used a balloon. We protected the anterior cerebral artery, and we were able to get the tip of the balloon directly into the AVM. With a relatively short injection, you can see that we took out this very large branch that's in the interhemispheric fissure and goes to the AVM and got reasonable nidal penetration. Not an aggressive embolization. We're not trying to cure it all the way to the foot of the vein, but we're trying to make surgery easier. So here you see the glue cast or onyx cast, and here you see the AVM. Here you see an angiogram showing that obviously the MCA feeders that come up over the cortex of the brain are still feeding this AVM. This is not cured. In fact, there's still danger from this AVM. But now you've got a situation where surgery becomes much, much easier. Could a truly fantastic surgeon take this out without the embolization? Yes. But in this case, embolization allows me to use this surgery to help to train residents and fellows and show them how to deal with an AVM like this with less danger and less fear. So here's the dissection done by, at the time, my chief resident, getting into and around the AVM. Here's this large feeder that we can find and clip with impunity. I think it could have been done without the onyx, but the onyx made us more comfortable. And then here's completion of the resection of the AVM, done with very little bleeding, and with a degree of relaxation that I think the embolization helps to achieve. This lady was able to go home 2 days after her surgery with a completely excised AVM and no deficits. You can see there, onyx in some ways is used just as you would use surgical dissection to access an artery that requires access early in the case. Was it absolutely necessary? No. Is it a safe and useful part of a surgical procedure? Yes. The last case I want to show you is a case from this last week. So we treated this at our center. It's a 26-year-old woman with a large AVM who initially presented with seizures in May, had embolization by another physician, was lost to follow-up, had another embolization 6 months later in 2018 after the first hemorrhage, and then re-presented just this month with sudden onset headaches. She had actually been seen in our indigent clinic a week prior with plans for new MRI and possible gamma knife radiosurgery. Here's her hemorrhage, here's her relatively large AVM, and I want to point out that this AVM extends all the way down into the ventricle. This AVM has feeders that come from all directions, but very hypertrophied lenticulostriate feeders. So here's the AVM after the initial embolization, and then here's the AVM prior to the most recent embolization. What we did can be seen between images 1 and images 2. What we did just prior to surgery was to get this little bit of lenticulostriate supply at the very bottom. Again, you're not seeing onyx spread all the way through the lenticulostriates. There's no attempt to cure it endovascularly, but taking out those little lenticulate deep red devils prior to surgery makes a surgery like this immensely easier. I've been having some trouble with video, so if you'll excuse me, I'm going to open a different window. Give me one moment. Okay, so this is actually Dr. Baskaya's trainee, Christopher Nickley, working again with 2 surgeons, with my partner, Jeff Sorensen, another fantastic surgeon. I don't want to take credit for this work, but they're beginning to get around this AVM and develop the plane. We've begun using the reposable Lawton micro scissors, which you can see here, which we're all quite taken with. The idea is they're neither disposable nor completely indestructible. And they can be used as an arachnoid knife and also be used quite well as scissors. But as you can see, they're developing this plane with the reposable scissors. You can see that the brain is relaxed despite the size, despite the hemorrhage. This is an AVM that can be dealt with carefully using sequential dissection as you should do with an AVM. With 2 surgeons, this was not a 24-hour operation. This was not a 14-hour operation. This was a good day's work, but the combination of judicious embolization and careful microsurgery rendered this, despite being a large ruptured AVM in a young patient, quite a safe lesion. So this is the beginning of the dissection. Obviously, I'm not going to show you the whole thing. And I can show you as well the end of the dissection. And here you can see developing the plane deep around the AVM. Now, the 2 negatives I want to mention are these reposable scissors. In this case, this set, we did essentially make a disposable because unfortunately, after cutting through onyx,
Adam, sorry to interrupt. The video is frozen. But anyway, I was also going to say 2 minutes. We're frozen on 1 frame.
All right, I'm sorry about that. Let me just go back to the talk. Can you see this now?
We're still seeing the video. It's frozen on bipolar and suction.
Okay. How about now?
Yes, now we see angiograms, yes.
All right, I'll be over in 2 minutes. So this AVM was resected. The only casualties were obviously with a fairly heavy onyx load, the AVM's a bit stiffer, so rolling at the end can be a little more difficult. And in this case, we did trash the micro scissors cutting through onyxed vessels. But again, she had no new deficits. So what I would take from this is where I am in my career is focused on training surgeons to be better than I am. And in the case of Chris Nickley, the partner who took that AVM out, he spent time with my opponent, Dr. Baskaya. He's learned endovascular. I think his judicious use of embolization and surgery so that the additive risk of both procedures is lower than the risk of surgery alone is the future of AVM surgery. So I'll end by talking again about my opponent, the evil Dr. Baskaya. As you know, Gru in the cartoon actually turned out to be a pretty good guy. So Jacques, you said this was one of his patients. If I'm not mistaken, it's even worse than that. Mustafa, as you know, loves kids and is somebody who really cares about his patients. I believe, he can tell us, but I believe that this is actually a child who was named after Dr. Baskaya because he resected the child's mother's ruptured AVM while the child was in the womb. So
Correct.
I know that the tradition in Miami is to assassinate your opponent's character, but I'm going to have to say, anyone who can do that is someone who has my respect, and I look forward to hearing his rebuttal.
Bravo, fantastic. Thank you so much, Adam. That was brilliant. I know you rushed to stay on time. You were on time with quite a bit of material. You can have a glass of water from all this talking. Thank you so much. That was great. Mustafa, go ahead. Unmute yourself.
Can you guys see now?
Yes, we see it and we hear you.
Thank you. I feel like I am back home in Miami. And thank you, Dr. Morcos and the co-directors of this symposium. I'd like to thank my opponent. I am terrible in preparing this kind of things, Jacques Morcos style, funny moments, pulling the cartoons, but you did very well. And in reality, I have been giving the name of Dr. Guru by our OR personnel here at the University of Wisconsin. They call me Dr. Guru for some reason. And I salute also all the distinguished panelists, especially my mentor, Dr. Roberto Heros, and other mentors if they are here from the Miami. So I have no disclosures, and my role is to do this battle against Adam, and he did wonderfully. And I know Adam is very analytic, very fair, and I think he told many things I am going to tell you guys already. So I'm not that he made my job much easier, and I have no disclosures other than loving microsurgery, neurosurgery. And then I'll start with, so I'm not good in words, you know, before Jacques Morcos starts picking on me, my English, my vocabulary, how terrible I am in English command, I'll tell you, my vocabulary is limited to 10 words. Surgery, surgery, anatomy, anatomy, the rest you may guess. Why do we embolize AVMs? So today's topic is the preoperative embolization. Is it helpful? Is it not helpful at all? So I'll be focusing on the preoperative embolization, and I'm not going to discuss about the role of embolization for curing the AVMs or pre-radiosurgery or for palliative reasons. And you know, I have been trained by many wonderful mentors and neurosurgeons. When I came here to University of Wisconsin Medicine, I made my mind, and I studied this very well with Dr. Heros. I wrote papers, book chapters, editorials about this, and this was my conclusion when I came to University of Wisconsin Medicine. Why I will use the preoperative embolization: elimination of the proximal ruptured aneurysm, obliteration of deep accessible arterial feeders during early exposure of the AVM, like ventricular stress or the thalamoperforators, stage reduction of the AV shunting in very large, very high flow AVMs like the ones demonstrated by Adam, reduction of the blood flow to the AVM to make surgery easier, faster, and less bloody, reduction of the blood flow to make surgery safer for AVMs located in or adjacent to the eloquent areas. After a few years, I changed my policies, or how I use the preoperative embolization. Elimination of the proximal unrupture. I can clip this aneurysm, and at the same time of the AVM resection, if it is ruptured or unruptured, or later. I can obliterate these deep feeders during early or late exposure of the AVM. I don't think stage reduction is necessary in almost all grade 1 and 2s and most of grade 3 AVMs. Yes, it can be useful in some grade 4s and the 5s, no question, and Adam demonstrated that very well. I completely agree with his assessment. Reduction of the blood flow to the AVM to make surgery easier, definitely not. And reduction of blood flow to make surgery safer for AVMs located in or adjacent to eloquent cortex. This I found technically difficult from endovascular point. We have 3 wonderful endovascular neurosurgeons here. But even if they do it, it's still you are doing the same dissection. And Adam went through this. I don't want to go over again. These are the basic principles of the AVM surgery. And again, surgical treatment, microsurgical, identify the feeders, open the sulci, find the feeders, relax the brain, and goes on and on. The main thing is this spiraling fashion dissection. And my philosophy, my surgical strategy in AVMs, identify the normal anatomy, identify the pathological anatomy. Don't jump and start taking the feeders right away, or dissecting the AVM on the brain side or the subarachnoid side. First dissect and lay out all the normal anatomy and the pathological anatomy. And to demonstrate that my surgical technique, this is not technically challenging AVM, but is a good capture of the video. That's why I'll prefer incidentally found right posterior temporal AVM. And to demonstrate my technique, I'll start again opening the dura carefully and dissecting these, making sure you are not avulsing any veins or the arteries early, and start dissecting it. And this is the sacred time between you and the patient, and turn your clock off. Don't think about the next case, what you're gonna eat that tonight, your date or anything else. This is the time you should meditate, and this is the time between you and the patient, and enjoy this dissection. Identify every single vessel, sulci. Opening this sulci helps to relax the brain. Also, these AVMs in the compartments identifies the normal anatomy, gyral anatomy, and identifies the pathological anatomy too. Without this dissection, you are rushing. If you start getting the feeders right away, superficial or deep, you're gonna be running into trouble, and then result won't be good. Keep the plane same, and the constant dissection, constantly, like you are doing the cadaveric dissection, finding out where these arteries going, superficial arteries and deep, before you reach to any conclusion. If you need to take the feeding artery, follow it and take it until it's the closest point, until it enters to the nidus. Don't take it before. Any question, putting the temporary clips help, so you don't sacrifice the vessel going or passing by. And identifying these en passant arteries is extremely important. So if you do this gyral sulcal dissection and identifying the pathological anatomy and the normal anatomy, then you can start taking the AVM. And constantly, it seems like time consuming, but at the end, it makes up for the time you spend for this dissection. It speeds up the surgery. So I define this gyrus as disease gyrus, and these feeder, for example, I don't know is feeding or passing by, so I keep dissecting, and by doing this wide dissection, you are identifying deep feeders too. It doesn't matter this superficial AVM or deep AVM, and you can go to the natural corridors like interhemispheric fissures, Sylvian fissure, identify these early. So I identify the feeders now. I'm going to the superior part of the AVM, and I'll keep carrying the dissection, and patiently, without taking any normal structures, injuring, damaging normal structures. And I'm following them. And this is the large draining vein. And now I identify one of the main feeders. I put the temporary clips, and once I am sure they are the true feeders, they are not the en passant arteries, I will take them with the permanent coagulation or permanent clips. So I'm dissecting whole entire gyrus, and the AVM start turning blue and soft. Now I can do more definitive resection, and I took those temporary clips, I replaced with the AVM clips, and now I start getting the deep, going deeper and deeper, finding the end of the cone, and keeping the AVM vessels, those dangerous red devils, within your dissection plane. Don't stay out of the dissection plane, then you'll have bleeding and you'll spend hours chasing those feeders. They go retract and you are in trouble. So I'll speed up for the sake of time. So that's those loops, keeping them within the dissection plane. I defined the normal anatomy, I defined the pathological anatomy, I took the feeders, I made sure I didn't get the en passant arteries, and there are still, they can be en passant arteries on the inferior aspect of the AVM. And once that's done, and the last and never retract the brain, and I'm not saying never, but most of the time you don't need to retract the brain, you can retract the AVM. And the last piece comes out, and taking the main and removing the AVM. And this was another en passant artery at the bottom of the AVM nidus. Result is good. He had a wonderful, very nice recovery. So now I'm going to show you when I got here first, my faulty judgment using the unnecessary preoperative embolization. 26-year-old female with incidental AVM, quite large, and had all kind of angiographic, anatomic, morphological features of the AVM for dangerous AVMs. And I thought embolization will help. We embolized, very nice embolization, and at the surgery, no help at all. All my interhemispheric dissection was limited because of the bulk of that onyx. And I had a hard time manipulating. Instead of spending less hours, I spent longer hours. So it didn't make it easier. I got all these branches anyway. Why did I embolize? I don't know. I came with that mindset here. I'm gonna embolize, use the embolization if necessary, but this was unnecessary. And this is another 42-year-old man with the so-called inoperable by many vascular neurosurgeons and many reputable centers. They do functional MRI and multiple bleeding episodes. See, this is like the inferior part of the leg area, foot area in the below the motor cortex is graded as a grade 4. Yes, in this grade 4s, I am okay embolizing some. And my mentor, Dr. Heros, taught me, Mustafa, you'll be tired at the end of the dissection. If you can, make the surgery, embolize the deep part of the AVM. That's what I did. They did wonderful, no complication. I took him to the surgery. I like to take them surgery next day. I don't like waiting after embolization. And this is classical ipsilateral side down interhemispheric dissection. And I found all these feeders embolized by onyx. I was there already. Then I start thinking, and embolization didn't make it.
Mustafa, sorry to interrupt you. Mustafa, your Wi-Fi is skipping a little bit. I'm not sure you can do anything about it. Sometimes your voice cracks and we lose some words. Are you opening many things at the same time, you think?
No, nothing.
No?
I'm sorry.
Okay.
This is, for example, that feeding artery embolized with onyx. And I cut this feeding artery. I'll show you. Supposedly embolized, still bleeding. And I was there in the large AVM in the interhemispheric fissure. And embolization didn't help me, didn't help me at all. Then why did I do? And good results. He didn't even move a hair. Wonderful, wonderful outcome. But he could have had complication from the embolization, and I wouldn't know that until we did this. So sometimes we need to be very careful with this decision. And then this is the second case. I start turning against the embolization in certain AVMs. 72-year-old, again, long-standing peripheral visual loss, progressive mental decline, and they call it inoperable. It's very significant AV shunt. And I thought slowing, like Adam did, this shunt, it will help me. We embolized the AV shunt, and suddenly the giant varix start thrombosing. And then he started having little more speech issues, cognitive issues right after the embolization. We did the quick brain MRI, is truly embolizing, and we thought he's having more T2 changes. So I took him back to surgery right away. And this is his surgery, that you are dealing with the large varix. See, this is the large thrombosed varix, and it's a big mass. It's like a 6-centimeter meningioma sitting on the nidus of the AVM, and you are working against it, retracting, and your surgical corridor is small, and you are trying to find the deep feeder, that's PCA feeder. Did we do it? We found it, but I had extreme difficulty, and I hold the embolization responsible for this because it thrombosed that giant varix. And we removed it after hours of dissection, and this is immediate post-op. He did wonderfully, except he still has the peripheral visual loss. So after these cases, I decide not to do any preoperative embolization except certain cases. And these are the cases: anterior cingulate AVM, and I didn't embolize, and I don't need to embolize. I mean, wide exposure, basic principles. And in the interhemispheric AVMs, I don't like to have a superficial drainage. I think that's something is wrong with the grading system. In this interhemispheric medial AVMs, superficial drainage makes surgery more difficult. Luckily, in this case, we managed that, and this is you see the drainage is coming from and going posteriorly and taking the side feeders one by one, and patiently following the principles set by our mentors, our pioneers like Yashar Goel, Dr. Heros, Professor Sugita, Spetzler, and the rest, and Dr. Morcos, of course. I'm not missing you, Dr. Morcos. So, and going on, exposing, now in this AVM, I am exploring and defining the pathological anatomy of the AVM at the bottom, because interhemispheric fissure allows me that, and there is no bulk from the embolization. And I find these vessels, and I can get the deep feeders right away. So I'm gonna speed up. And get the AVM, and then there was and then something I learned from Dr. Heros: if there's unusual bleeding, and look for a residual. And we raise the blood pressure a little bit for 10-15 minutes, and if there's a bleeding, there's a residual AVM, and I found the residual AVM around this draining varix. I removed that part, and again, good results, good outcome, and no embolization. Another large AVM in young patient presented with seizures is quite large, and I didn't use any embolization, and I used interhemispheric exposure. You will see, yes, it's tough sometimes. There was a calcified falx, draining veins, but we are microneurosurgeons. If we cannot do this surgery, if we cannot separate this safely, I think we should do something else. and exposing from all the way from posterior to anterior, exposing the olfactory tract, preserving them, and getting the AVM out. Then coming superficial. Now we got the deeper part. Easier part is the superficial, defining borders, going there, and taking the and preserving the olfactory nerve, everything else, taking the AVM out. Did I really need embolization? No. He did again wonderfully and very good outcome. And this is hippocampal AVM, young female presented with seizures. I don't think anybody will embolize this for curative reasons or preoperative as a preoperative adjunct. And we didn't. I used the subtemporal transfusiform approach and find the proximal arteries, choroidal artery, PCA feeders, and the rest will come. And sometimes we have emergency situations. This patient known with AVM, seizure disorder, and present to us as a new patient, ruptured intraventricular hemorrhage. I didn't have time, he was herniating, and I don't need angiogram. If I know where the AVM is, I don't need to know anatomy. I know where the feeders can come, where the drainage will be. My job is to first save the patient's life, and I went to the lateral ventricle, suction all the intraventricular blood, relax the brain, and now I am there. Next question, should I stop, resect the AVM, or come back? I know Dr. Heros' blood pressure is going high now, but I decided to stay and resect the AVM, same sitting. I don't know what's gonna happen, and I don't wanna give any other chance to him. And that's what we did it. This is actually starting from the inferior temporal gyrus and involving the fusiform gyrus and going intraventricular. That's what we did. We removed it and put many ventriculostomies, good angio, immediate CT scan. He was comatose, herniating in 3 weeks and 2 months. And in 1 year, his MRS score actually went up to 1. So this is, sometimes you don't need time. And I understand it's good to wait in some AVMs, but in some emergency cases, you are there, you can tackle the problem. So motor cortex AVM, small, no embolization. I don't think embolization will help you here. You do the same dissection. So I'll skip all these videos. Yes, every procedure we do is associated with the risk. There's no zero risk for surgery, zero risk for radiosurgery or embolization. But even if it is not high, they are still significant. This meta-analysis shows 2.6% hemorrhage per procedure, almost 5% per patient, morbidity, mortality, 15% to 45%. It's not zero. And it's shown by the others, it didn't help them. And these are master AVM surgeons. It didn't make it easier. They didn't find less blood loss. Then why are we embolizing the AVMs? Is the risk worth it? My answer is no, but my mentor taught me this: overall treatment-related risk of morbidity for a particular patient will be lowered by performing both embolization and surgery rather than surgery alone. Preoperative embolization is not needed in Spencer Martin grade 1, 2, or 3s. Probably, I should say, most of the 3s. Very rare cases you can find the use of preoperative embolization. In certain cases, desperate cases, you need to operate grade 4s or 5s. Then you may use preoperative embolization to help the surgery and make this AVM operable. And I don't think we should follow any algorithms. And I'm 100% agree with Dr. Rose, he's against these algorithms. Treatment should be individualized for that particular patient and particular neurosurgeon. Yes, if you cannot deal with it, do whatever you need to do it, or send someone else. Thank you. Thank you for taking too much time. I'm happy to take any questions. And again, I salute my mentor, Dr. Heros, and I'm happy to hear his critics.
You were actually exactly on time, both of you. Fantastic. Great. Better than I even expected from both of you. That's spectacular. So thank you for stop sharing your slides, and I invite Dr. Heros to share his slides and give his critique.
Can you hear me?
We can hear you.
Perfect. So I need to begin by saying what a pleasure it is, you know, when you reach the stage I have reached where I'm not doing this anymore. What a pleasure to see that somebody who was my resident like Mustafa can do this so much better than I ever could. So that really, I well-deserved semi-retirement from surgery to see what Mustafa can do, which I could never do as well as he does. He plays with his AVMs almost. And that, of course, that's a pleasure that I have very often at home by watching Dr. Morcos operate and do just about anything he does much better than I could ever do it. So that makes me happy. Let me see if I can share I'm just going to show a couple of slides just to emphasize some of the points made. And let me see if this works. Okay, and then, okay, can you see the slide?
Yes.
Okay, so this is the point is to think about why you're doing the embolization and when is it necessary or not, and the risk of embolization, as Mustafa emphasized, needs to be taken into account. This is an AVM that is an ugly AVM by any stretch of the imagination, but if you analyze it, and I'm sorry that I don't have very good slides, but if you analyze it very well, all the feeders to these AVMs are really feeders en passage. They're feeders from the anterior cerebral artery, from the A1, from the anterior communicating complex, and then from the A2. And they are all slight little, tiny little branches that come off the main branch that is artery en passage. So in this kind of case, I think embolization can be dangerous. You can occlude the artery en passage. It's very difficult to embolize, and it really adds nothing to surgery. So I did this case without embolization. I must say that it took me very long. This operation, this was almost a 24-hour operation because it involved two different surgical positions we had to change completely to first come under follow the A1 and take all the branches from underneath, dissect the AVM from the anterior aspect of the hypothalamus here, and then turn the patient over, come above interhemispheric, and then skeletonize essentially the A2 and taking all the little branches coming to the AVM. And then you can see that after surgery, the two, I don't know if you see, but there are two pericallosals that now feel very well and are completely preserved. And the AVM, of course, is gone. This patient did well. He had some problems with hypothalamic issues, electrolyte issues after surgery that took a while, but eventually he did very well. He was a young man. So an AVM like this can certainly be done without embolization. Now, here is one that I also did without embolization. I'll tell you what happened. But if you look at it, this is an anterior vermian AVM. You can see here is fed essentially by the two superior cerebellar arteries. They're all branches of the two superior cerebellar arteries on each side, so that by coming infratentorial supracerebellar, you're looking at the two at the branches at the feeders to the AVM, and I thought that it was not necessary to do preoperative embolization. The point that I missed and my error in judgment here was to not realize that this was a very high flow AVM and that you could have a problem with these veins. It's something that I never thought about. But actually, the surgery went well. Dr. Morcos actually came in the room, forgot, 3:30, 4 o'clock, 4:30, to see and he was surprised to see that we have gotten the AVM out. And he made just one observation. And I looked at him and said, what am I going to do with that, Jack? But he looked at the vein of Galen here that you can see here. And with each respiration, the vein of Galen was collapsing completely. It was hugely dilated. And then, of course, after taking the AVM out, now you had essentially hypotension in that vein, and the vein would collapse with each respiration. And Jack Morcos asked me and said, are you worried about that vein thrombosing after surgery? And I said, well, what do you want me to do? I can heparinize the patient. Well, sure enough, the patient did not wake up, was in a coma after surgery. You can see that the AVM was resected. And then if you notice here, there is no feeling at all of the deep venous system. And here is what happened. This is a CT scan. What you can see here is a thrombus on the vein of Galen. And then this is thrombi. This is a fresh thrombus on the veins, the basal veins of Rosenthal. So the entire deep venous system on this patient thrombosed because it was used to this very high pressure. Now you took the AVM. I think if we had embolized this AVM on stages to reduce the flow gradually, I would have avoided this problem. Actually, this man, and Jack knows the person, came from the Philippines to be operated because he was the uncle of a Filipino nurse of ours. After about 3 to 4 weeks, he began to wake up, and eventually he woke up. He still was not himself, never recovered 100%, but he had a very useful, very functional life and recovered surprisingly from this. Now, the next case and the last case I'm going to show you is the mistake that you can make by trying to embolize an AVM that absolutely should not have been embolized. This is a small AVM, grade 2, 1, whatever you want to call it. And any one of us could have removed it without any difficulty. But the neuroradiologist and endovascular neuroradiologist that was doing at that time the embolizations with us did the angiogram, talked to this patient, and told the patient, you know, I think we can occlude this AVM completely with embolization, cure you, and you won't have to have a craniotomy. And partly because the patient had already been predisposed to have this done, I allowed this to take place. And in fact, the AVM was embolized, and I had this call after the embolization saying, Roberto, I almost got the AVM completely. It's 90% gone. I still preserve the veins, but I embolized 90% of the AVM. I couldn't embolize it completely. You're going to have to operate tomorrow. Well, of course, when I got that kind of call, and that happened not just on this patient, but on 2 other patients, you don't sleep well, because what happens is that you get this kind of hemorrhage from this ill-advised attempt to embolize and occlude completely an AVM that could have been removed very easily with surgery. So I differ a little bit. I kind of fall in between the two of you guys. I differ a little bit from Mustafa. I do think that that almost no grade 1 and 2 AVM needs to be embolized preoperatively. And I think that most, if you're going to operate on a grade 4 or a grade 5 AVM, almost all of them probably can benefit, unless you have a surgeon like Mustafa, can benefit from embolization. And I think actually most grade 3 AVMs, in my hands at least, could benefit from preoperative embolization. Some don't need it. obviously preoperative embolization has to be very well directed by the surgeon and not, and if it's going to embolize, I really think that it should be a surgeon that can do both the surgery as well as embolization, because then you know what you need done for surgery. What you need is those feeders that are inaccessible at surgery. Is absurd and dangerous to embolize superficial feeders, mesocerebral feeders, and so forth, that you can see earlier in the surgical exposure. As Mustafa said, it's imperative for you to think that the risk that you're adding by preoperative embolization has to, the overall risk of the package, if you will, of preoperative embolization plus surgery has to be less than the risk of surgery alone. Otherwise, you should do just the surgery alone without preoperative embolization. So those are my comments, and with that, I end, Jack.
Thanks, Roberto. Anybody from any of the speakers want to respond or just make a comments to Roberto? Otherwise, I'll ask Atul to share his slides. And
while he's bringing them up, I will say, you know, what we see with the spreading of endovascular is a proliferation of the notion that you're going to consent a patient for diagnostic angiography and embolization all in one go without a careful thought about planning of surgery. And I think one of the lessons that Roberto is teaching us is that that sort of idea is very dangerous. I actually think there's a great role, particularly with transradial angiography, for having a team that can look at the MRI, look at a complete, careful diagnostic angiogram, which is a very safe thing to do, and then make a plan rather than shotgun approach, you know, angio and embolization at every center in the United States. So I think, unfortunately, we're going more towards diffusion and over-aggression of endovascular AVM treatment.
good to hear you say that. I mean, that's true. It's happening a lot in many places. I agree. Atul, unmute your microphone, please. And then again, so thankful you're joining us middle of the night, your time. You're still muted. Bottom left. Atul, we cannot hear you. Can you? No, Ignacio, can you unmute him, or he has to unmute himself?
Can you
Trying to unmute
now,
him.
Yeah, we got you. Now we hear you, Atul.
Okay, so arteriovenous malformation, I consider, Jack, this as the last chapter of neurosurgery, completely last chapter. You see, it is not just a technical situation. It is difficult operation. It is dangerous operation. It is life-threatening operation, but it is also life-giving operation. There is no question in my mind that technique at its absolute end, philosophy at its absolute end, understanding neurosurgery at its absolute last is the bottom line of treating arteriovenous malformation. There is no question about that. So I am in the, you know, personally, I don't think embolization is a very important tool for me for surgery. And for me, there are two types of treatment for AVMs. One is you just leave it. If you think you cannot do it, if I think I cannot do it, I just leave it, or I go for surgery. So there are two treatments, and there is nothing in between. So I have made my own classification for AVM surgery. This is for me. This is not for Mustafa or for anybody else. This is for me. I call it a dynamic classification. This word easy, I know it is not such a great word in neurosurgery, particularly for AVM surgery. Difficult but safe, very difficult and risky but possible, and not safe or not possible. This is my classification. So when I see AVM, I have to see, yes, I can do it, or maybe it is not possible. So that decision, whether I can do it or not do it, is an absolutely important decision. So this is one straightforward, simple AVM, but this patient is almost asymptomatic. Now the question is, in asymptomatic patient, whether you would like to do it. And if you say, I will not like to do this AVM, then of course you don't do AVM surgery, because this is one of the most straightforward AVM surgery. Doing this surgery, whether you will be able to control all bleeding, whether you will be able to completely resect and come out clean, you cannot say, I will leave 10%, I will do partial resection. This is not tumor surgery. You have to remove completely and absolutely sure that you have to do it. So this asymptomatic patient, of course, this was removed, and this is the AVM, and this patient is cured. This is another patient, has moderate headaches. A farmer, a poor man from a village, he comes to me and with this AVM, moderate headache. So you have to have a feeling, yes, it is safe. Yes, I can do it. Yes, I will be able to resect it. Imagine if you, for headache, he comes and you create hemiplegia. For glioblastoma, you create hemiplegia that may just be handleable by the patient. But for a benign lesion like this, you create hemiplegia, this will not be accepted. But you have to be, every AVM has some good points for surgery, and that has to be exploited very nicely and elegantly. So I had initially said no for surgery, but this gentleman came back to me and he forced surgery on me. Basically, nothing should force you. There is no other indication for surgery. There is no other parameter for surgery. The parameter is for me to decide, yes, I can do it, and I can do it safely, and I can do it effectively, and I can cure this person. If I think there are dangers too many, then I should be wise enough to withdraw from the field. Of course, this gentleman I removed, and this is the preoperative angio. This is done several years ago. This, of course, was completely removed and cured. And you have a person who is cured and young boy. And this is the AVM. How to remove AVM is a question. How to get to the big vessels, how to get the middle-sized vessel, how to identify normal from abnormal. That is the critical. You see, you cannot take a normal vessel. You take one normal vessel, you completely devastate the person. How to handle small vessel. I think that is an absolutely critical situation, and that forms the basis of surgery, and that forms the basis of resecting it completely. Now this lady comes, youngish girl, comes with very severe headache and an AVM in a very resectable kind of situation. Here, of course, you cannot, with this kind of headache, you have to remove it. So you have to plan the surgery properly. You have to plan the surgery elegantly. You have to know which vessel to take first, which vessel to take next, which vessel to avoid, which vein to avoid, which vein to come last. There are hundreds and hundreds of things that have to be decided and has to be absolutely meticulously prepared. So AVM surgery is absolutely not easy. It is not for, why I say embolization will thrive, because there are not many people in the world who are doing AVM surgery. And embolization and interventional radiology are here to stay in AVM and here to thrive, because surgery is difficult. You can have such a situation where it bleeds, and it bleeds to an extent that you just cannot control, and you can have a disastrous situation. But if you have to give this beautiful smile, if you have to cure a person, you have to learn this beautiful thing. If you really ask me what is the thing that thrills me in neurosurgery today, is AVM surgery. It just vibrates me. But that vibration does not mean that I take a decision and I operate on a case which during operation I struggle, and I struggle to the extent that I will not be able to get back. This is another AVM. I asked the panelists, this AVM only complaint is giddiness, whether you will like to handle this, whether you will like to do embolization and leave it, whether you will be able to take the risk of resecting it. I'm not sure whether I will be able to take that risk. But this was done 10 years ago. I was a more ambitious and more ruthless kind of a situation, and I removed it, of course, beautifully. And over the period of time, I have loved to enjoy these cases. These are difficult situations, dangerous situations. But now for 10 years, this lady is having no giddiness. But you know what? To do this operation, if I had created for giddiness hemiplegia, for giddiness some kind of a big deficit. So you have to know you cannot create deficit in this situation. This patient, another question. AVM comes with only complaint of convulsions. In a dominant hemisphere, speech area is in question, removed properly, successfully in this situation. You remove AVM with convulsion, you are not even sure that convulsions will go or not, but this was removed some years ago, and this patient has done it quite okay. This is another patient, only complaint of giddiness. You see, now giddiness, of course, is a big symptom. You cannot say, okay, you just enjoy your giddiness. You cannot say, I do some little bit here, embolization, and little bit there. This patient has to be cured. You have to learn the art. You have to learn the philosophy. You have to learn the dynamics of AVM. And you have to have the handle of bleeding control. Bleeding control is not everybody's game in AVM surgery. You go inside, you go like a king and come like a pauper. You will be, you will make mockery of your own self during surgery. It will bleed from here, bleed from there, bleed from 3 or 4 points. How to handle that situation, how to handle yourself, how to handle the entire theater is not easy. But I will say that it is, of course, possible, and possible in this situation. This is another case, of course, bleeding. When the AVM has come with bleeding, then you have an argument to say, yes, there is no question. It might bleed to death on the next occasion. So then there is now this AVM, it looks quite formidable, but there are some beautiful points in this AVM. This is large PCA feeder, large feeders. You have to come and interhemispheric, learn the approach, interhemispheric approach. Majority of big feeders in all the AVMs are from the interhemispheric fissure. How to open, how to dissect, how to resect, and how to develop a plane of dissection around how to identify normal from abnormal, how to control big bleeding, how to is beautiful, is absolutely fantastic. But fantastic does not mean demolishing. You show beautiful trophies. You see what I am showing is beautiful results, beautiful thing. But what about disasters? You can have disasters. And I am not saying for sure I have not had any disaster. That is not the purpose of my presentation. So this is one AVM. I'm saying that AVM surgery is beautiful. AVM surgery can be done in complex situation near the vein of Galen, near the velum interpositum, but there are some good points. You see, this good point in this case is large anterior cerebral artery feeder. You come from interhemispheric fissure, get to this artery first and then dissect, and then of course you can do a beautiful resection, whether you are prepared for this. I must tell you, not many surgeons in the world are prepared. So this patient came with severe ataxia and giddiness and large AVM. Long time ago, I did this for a mathematics teacher. You see, there are several aneurysms here. When you see aneurysm, it is high flow. You will ask me, what is the major issue in AVM surgery? The degree of flow, the high flow. More the high flow, more difficult, more furiously it bleeds during operation. You cannot control that bleeding by any kind of embolization or any kind. I don't think embolization, preoperative embolization was done. I work in a center in India, largest interventional radiology department in probably in Asia, if not in the world, doing, many of my cases come with preoperative embolization. And I must tell you very honestly and very, without any ego or pride in my character, that I don't get terribly comfortable when the patient is embolized, and not that it makes my life easier. Still, I have to dissect. I must tell you that even if you have a wonderful embolization, you still need a very, very fantastic surgeon to operate on these AVMs. And of course, you can do it. And of course, you can remove it. Now, what I have to give this case for discussion is, this is a case is a very high profile politician of our country, came to me with very high recommendation. You see this AVM, and now this is quite a high flow AVM, but because he came with recommendation and because he high profile, I took a decision to operate and to remove it. And of course, I removed it. But you know, I landed up with a very dense hemiplegia following surgery. Now I am wondering all the time, believe me, whether I should have done it, whether this high profile nature of this person forced me into this operation, and whether, you know, this patient had only convulsions, whether I should have just left him. Of course, he has improved quite remarkably, but he's quite, you know, significantly not in a normal situation. So that decision, that, you know, there is no other, you know, only feeling is, only thing that you have to do is, I can do it. I can remove it completely. I can remove it absolutely. You know, there is no running halfway. I remove partially. I remove, you know, come second stage. There is no second stage here. Enter the theater, you have to come with the AVM outside. So that, and you have to come with the patient outside. You cannot leave the patient on tube and have a disaster at hand. So that, you know, you need to be very intelligent neurosurgeon. You have to be very, very philosophical, understanding neurosurgeon. And this is actually the video. I don't want to go into that. This is another AVM, which is the last case which I'm showing. Multiple aneurysmal dilatation, came with a huge bleed, and this is the AVM in quite a formidable location. And I will, if possible, Jax allows me a little bit surgery for AVM. Wide exposure. You have to have a very huge exposure. You cannot do mini exposure, micro exposure, or endoscopic exposure. You have to have a huge exposure. Come circumferentially. You see, this is the AVM. You have to have bilateral anterior cerebral artery under control, bilateral internal carotid arteries under control. As you know, it can bleed, and it can bleed furiously. There are big aneurysmal dilatation. This is a high flow AVM. And high flow means it will bleed on your face. You have to have control on the AVM, completely control on your own self. It may bleed from here, bleed from there, bleed from more. Those who do AVM surgery, not many. This breed of AVM surgeons is not too big, Mustafa. Don't worry, you will be, you know, you keep on doing, and you will be unique in the business of neurosurgery, because not many people can do it. And if they do it, they can, you know, they can make a mockery. And I am saying that it is a only treatment which will give cure to the person, only thing that will completely cure the person lifelong. This is a benign condition. Surgery is the only answer. You know, you give them a partial here, partial there, that will not be good enough. You have to do complete, partial, and you know, here and there and there and here. Those kind of artificiality will not work here. It will be here, it will be complete, and it will be final. You know, nobody in the world can show in few minutes the intricacies and the nuances of AVM surgery. This needs the complete gamut, complete, wholesome. This is complete neurosurgery in its entirety and in its beauty. I will say we should learn AVM surgery. All neurosurgeons should learn. But I can also, Adam, don't worry, you will thrive, and you will completely beautifully thrive, because this breed of AVM surgeons is surely, definitely reducing, because, you know, who wants to enter into this kind of a bleeding situation? Who wants to enter into trouble? Who wants to enter into a situation that can, you know, completely demolish the person and demolish the neurosurgeon? In any case, I don't want to be negative. AVM surgery, beautiful surgery. AVM surgery, my life. AVM surgery, my thrill. And AVM surgery has given me such beautiful pleasure, and also such great disasters and things which I do remember in my lifetime of neurosurgery. And this is that case, and cured, completely cured, possibility of cured. And thank you, my dear friends, with some here and there things about AVMs.
Thank you, Atul. Thank you for your message is loud and clear. Thank you. And just for the sake of time, I'm going to keep moving to the other panelists so that we can all have a conversation at the end. Stefan, could you load your talk, please, and unmute your microphone? We can see your slide, but you're still muted.
How about now?
Right. Yeah, here you go.
Okay. All right. First, I just want to thank you for the invitation. I also just want to echo sort of what Dr. Arthur had said, and I think he's absolutely right that there's a lot of people doing endovascular surgery and endovascular treatment of AVMs, and they do this sort of combo consent. And I think the value of doing a diagnostic angiogram first and sitting down and really studying the angiogram, and particularly as a junior faculty, going through the angiogram with your colleagues and coming up with a good plan and not feeling pressured one way or another to either embolize things that maybe you wouldn't otherwise. I think that the value of that is just cannot be overstated. So I, again, as the junior most person on this panel, I thought I would take that opportunity to actually share a case that I haven't treated yet and sort of get the opinion of the panel here. This is a case of a 38-year-old woman who had a transient episode of alexia while reading. Saw her in the clinic, hasn't had any other episodes after being started on an anti-epileptic, neurologically intact. Her MRI shows this AVM. I'll have another sequence here in a second. And we did get a functional MRI, which showed left lateralization of the speech and localization just on the anterior border of the lesion. So T2 sequences here, and the angiogram here showing some feeding to the AVM from the posterior circulation, but primarily from a large PCOM and MCA branches with superficial venous drainage. And so I'm just like to sort of get the opinion of the panel if any preoperative embolization would be considered, well, if treatment in general would be considered, if preoperative embolization would be considered.
Can everybody maybe unmute their microphones, and maybe we can have Mustafa answer first, then Adam, then our panelists. Mustafa, are you muted?
Yeah. Stefan, does this patient work? What kind of work does she do?
Yeah, she's works in an office as an assistant. So she's on phones. She's heavily communicate during her workday.
And her alexia is how bad?
She just had one episode where she was reading and then completely sort of went into a fog, a daze, she says, and then she doesn't know how long it lasted, of course, and then it resolved, and she was started on an anti-epileptic by a neurologist and has not had another episode like that since.
I mean, she has a large AVM, right? I would say maybe grade 3. And she's young. Profession should be taken into consideration when making decision, and decision should be for cure. I think this can be resected without embolization after counseling her and the potential temporary issues with the speech and cognition.
Mustafa, can I ask you a question just to push you on this a little bit? Suppose it doesn't, but suppose its main draining vein was superficial, and on the way of the subtemporal approach to get access to the PCA feeders. Would that make you do a pre-op embo because you're worried that the PCA feeders might be hard to get to early in the case?
No. I mean, I dissect these veins, posterior temporal veins, and in particular vein of Labbe when I do very large tumor surgeries. And there's a way of dissecting them, elongating them, actually I think introduced by Sugita. And then, so I don't think that's a problem. But superficial drainage in any AVM, I don't like.
Okay. Adam, how would you tackle this case? Or would you tackle this case and how?
So my concern in this case, Stefan, is I don't know how diffuse the nidus is as it trails off into the speech cortex there. And that's where the rubber hits the road for me, is the diffusion of the AVM. If it's a quite focal AVM, and the MRI seems to indicate it is quite focal, then as Mustafa indicates, I think you can resect this. I'm not sure an embolization is necessary or helpful in this case. If you are worried that it's diffuse in that location, I don't think that you have to operate on this. I mean, this is someone who's presented only with a seizure that's controlled on medications. The other thing I'll mention, and I wondered what people think about this, but I've heard Michael Lawton talk about for grade 3s like this with a higher supplementary rating, treating initially with radiosurgery to allow the AVM to retract a little bit from eloquent cortex, and the fact that that makes surgery easier in some cases. I don't think I would do that here, but my main concern is the speech functionality. So Jacques, I would want to study this a lot more to try to be sure that I could hug that margin of the AVM without getting a deficit. That I think is the most important thing in this resection.
Roberto, how do you analyze a case like this?
Mustafa is going to be very disappointed at my answer, but and I think Jack, you nailed it on the head. For me, it is very. I think I would have to go subtemporal to get access to those deep feeders from the posterior cerebral, in this case, posterior communicating and posterior cerebral, which becomes a posterior cerebral. Anyhow, you have to go subtemporal, and I'm terribly scared of subtemporal retraction, with particularly on the left side with the vein of Labbe. Even if you didn't have arterialized veins, I suspect in this case the vein of Labbe is going to be arterialized. That would make it even more risky. So I would use preoperative embolization of the deep posterior cerebral feeders and then resect the AVM. I think it's below the speech area. And I don't think, if there is a speech problem from the surgery, I don't think it'll be a serious permanent deficit, but I would embolize it preoperatively. Sorry, Mustafa.
That's okay, Dr. Ross. Stefan, can you put the coronal MRI images? MRI coronal, yeah. I mean, there are ways of getting around this, and another way is the coming under the occipital, posterior temporal, on the tentorial surface. So technically, I mean, there are so many things you can do to get around the superficial draining veins if you are too concerned about the draining veins. My concern also for the postoperative deficit is not the speech, receptive speech, but is this area is there are so many fascicles going around, and in this area, temporal occipital association fibers. So she may have temporary issues with the visual understanding and the execution. But again, I'm going against Dr. Heros, but I think there are ways of coming around this AVM, not through subtemporal, but occipital too.
And you know, just let's put in a plug, Mustafa, for the Not necessarily for this one, although it could be considered. Supracerebellar infratentorial transtentorial approach.
I thought about it.
Yeah.
And Stefan showed when I solved especially these coronal images, it's possible. And if you do, actually, if you do your approach in a way that you can get subtemporal, occipital, suboccipital, I mean, infraoccipital, and the way you said this supracerebellar transtentorial, that's another approach you can do. And I do that in the parahippocampal tumors sometimes. If I'm not sure, I will get entire tumor through one approach. I do wide exposure, so I don't burn the bridges.
Crazy suggestion, Jack. Horrible.
No, not for this. I said not for this one.
This is not a tumor. This is a damn AVM.
No,
You can't, if you
that's
get
true.
into
That's
trouble
true.
and you're getting some bleeding, you're talking about the supracerebellar transtentorial approach.
Yes.
If you get into some bleeding, you're out of, the patient would die. Don't have control of the situation.
Not
Not
for this.
A tumor, I would never do this, that with, you have
not alone, but you can in the same exposure you can get some of the exposure through that stuff. Not alone.
You guys are too much. No. What about somebody young listening to you guys and is going to try that? No.
Atul?
You can do it. But
Yes, yes. Jack,
Atul, resection without embolization, correct?
yes. Now the thing is, this particular case, if I am worried about AVMs, I am worried about left parietal AVMs. You see, it is not just speech, motor speech, sensory speech, but you can have very dramatic issues. Of course, this is very low down, low near the tentorium. This is not too much speech, speech eloquent, not so much to that level. But if it was a little bit more higher, then I would worry about, the efficiency of the problems of calculation, problem of
Gertzmann syndrome.
Yes, Gertzmann syndrome, rather than just motor and sensory speech. But this AVM, you know what, whenever I see an AVM which is fed by the PCA, like in this particular case, I like to come interhemispheric and get this interhemispheric, this PCA feeder first. And of course, this is very, very low temporal, and you can remove little bit of temporal, inferior temporal gyrus also if it is necessary. I think this is for surgery, and there is no other treatment. You cannot conserve this patient because this looks a little bit dangerous and she might just bleed. Now she's having convulsions. These convulsions can go uncontrolled. This AVM should be removed. That is my answer. Now, Jack, what I want to show you is one investigation. Can I share my screen? I want to show you one investigation, and you will like it, I'm sure.
Okay, let's let Stefan finish the case. Maybe let's save it till.
Yes.
I want to make sure I cover everybody. Stefan,
yes.
you have the microphone.
All right. Well, you guys have been no help. We got a bunch of different answers.
What did you expect?
So it was a similar discussion here. We got a bunch of different answers on how to do this. I'll keep you guys updated. She's going to come see me again in clinic, and
you haven't done it. Oh, okay.
No,
Okay.
this was me taking advantage of all of the senior help here as the junior guy on the panel to get some opinions on how to approach this.
But it's something that Atul says that's very true. I mean, as you know, Stefan, these conceptual answer, what's the best way to do something? You have to add in the hands of the person doing it, correct? I mean, whether Adam says something or Mustafa, you've got to, I don't need to tell you that. I mean, it's just you have to gut feeling what's best in your hands, whether PCA embolization will help you because you don't have to go to that deep dissection. These are decisions for you, correct, to make, as opposed to a panel to tell you.
Stefan, we are here 2 hours north of you guys.
Okay, how about I invite Jeremiah Thank you. Good luck, Stefan, with this.
Thank you.
Jeremiah, share your case, then we will open it up for more talking.
Okay, thanks for the invitation. So I'm Jeremiah Johnson. I want to share a case. It's actually not too dissimilar from Stefan's case. It's lots of nuances. I'm curious what everybody thinks should be done. So this is a 32-year-old female who is the mother of 4 children. When I first met her, her youngest was about 1 year old and her oldest was 5 years old. Her mother died at age of 47 from an AVM rupture. She's an avid runner, and she had some headaches after running for a few days and was concerned given her mother's history, got an MRI, which I'll show you a video of here. So this is a right parietal, temporal, extending slightly into the posterior frontal, maybe a hint of parietal. And I wanted to show you the deep part of it, to take particular note. It does come somewhat close to the, oops, got interrupted, somewhat close to the basal ganglia, some of the flow voids, posterior thalamus, and deep near the ventricle. Here's just a couple of other views. Clearly this is rather large, but also in a relatively favorable area for surgery for the most part. So in addition to her AVM, she also has a couple other things going on. So this is her AP view of a right ICA injection. So this AVM is fed from the right MCA, multiple large feeders to it. This vessel, which you see take a tortuous turn and come back here, is actually the anterior choroidal. So it's recruited the anterior choroidal. And in addition, she has a few somewhat dysplastic feeding artery aneurysms, 2 major ones on the MCA, 1 little bulge at the bifurcation, and then an additional one when you angle different is about a 2 millimeter outpouching here on one of the large MCA feeders, and you see some dysplasia up here as well on a distal branch near the AVM nidus. In addition, this is the PCA injection. She has irregularities of the P1. There's actually a real aneurysm here in the proximal P1. This is more like P2. There's what looks like a recruited small perforator that's dysplastic. You'll see better in a different injection in a second. But all these large and engorged PCA feeders to the nidus. All in all, it measures about 5 centimeters. She has multiple feeding artery aneurysms. And since she had so many young kids, she's a primary caregiver for these 4 children. Her husband works in the oil industry and they're away from their families, so she's all that her children have, so to speak. This is what the venous phase looks like. So it's a superficial venous drainage, a few small veins up to the superior sagittal sinus, as well as this more or less enlarged labbae. And what you can't see on these still images is how high flow this is, which is why she's developed these feeding artery aneurysms, I suspect. But this shunts very quickly throughout to this very enlarged draining vein. Let's see, so there's a dysplasia. So she actually did not want to undergo treatment when I first met her. So our plan was to watch these feeding artery aneurysms. Her baby was still very young. And over time, it actually grew from about 3 millimeters to closer to 4.5 millimeters. And you see this like little enlarging cone at the top of the aneurysm. And this is straight AP view. So it grew, but it also points directly medial and quite anterior. So we thought this would be challenging to treat just about any way from the straightforward anterior through the basilar artery. So the first thing we wanted to do, because she still was not ready to treat the AVM, was treat this feeding artery aneurysm of the P1. So
hold on, Jeremiah, maybe we can, before you tell us what you did, Bobby, can you hear me, Bobby? I don't know if you had a chance to look at the case, or I know you're working. Would you, I don't know if you care to comment on how you would handle these nidal proximal aneurysms with this AVM when you, I'm sorry, I don't know if you were paying attention because they were calling you in the angio suite. Did you get a chance to see those aneurysms?
Yeah, sorry, I may have been a little bit distracted, but it sounded like reasonable size AVM with those associated feeding aneurysms.
One of which has grown over time from, I think, 2.5 to about 4 millimeters.
This proximal P1 went from about 2.5 to 4 and is growing over time here.
I mean, tough one, I think when the aneurysms are further along and closer to the AVM, a lot of times I like to just treat the AVM with the notion that you're going to return to sort of a normal flow state. And a lot of times the aneurysms will dissipate. The ones that are near the basilar that are fairly far away from the AVM, and those that are near the ACA that are, again, far away from an AVM make me more nervous because they're still going to be getting a reasonable amount of flow even if you take out the AVM. All those look dysmorphic and fairly wide base. So I think, you're going to be challenged to get a reasonable result endovascularly without a stent, even with a balloon-assisted coiling. One option would be to try and do a balloon-assisted coiling, get a reasonable result, then deal with the AVM, and then come back and treat with a stent as needed. Another option would be, I guess I'd have to look at the rest of the imaging, but another option would be considering microsurgical clipping if you're going to address the AVM as well. I probably need to see the rest of the imaging. Sorry, I was getting distracted.
That's okay. Adam, what's your advice here before Jeremiah tells us what he did?
I think flow-related aneurysms and AVMs are interesting. In some grade 5 AVMs that we didn't want to treat, I have treated flow-related aneurysms with good effect to reduce the risk of rupture, and it sounded like that was the direction Jeremiah was headed. In the absence of strong input from the patient, which is what he was starting to say, I think I would recommend excision of this AVM. I have seen flow-related aneurysms spontaneously regress and go away once you remove the AVM. This is one that I suspect Mustafa, Atul may say they're going to take out without embolization. At our center, what I would probably do is treat those PCA feeders with embolization. They're going to be a little bit more difficult to reach surgically. And then you also could consider a very small catheter in that enlarged anterior choroidal. There's some risk there, but I might consider taking, for instance, a flow-directed microcatheter out that anterior choroidal and just putting a dab of glue into the AVM from that perspective. I think that endovascular approach would allow you to do the open surgery, very comfortably. I think the majority of the MCA feeders are well treatable in surgery, separating out the en passage feeders from the terminal feeders. And I think if the AVM was removed, with which her family history I'd want, then likely those flow-related aneurysms are going to heal on their own without you needing to stick anything in them or stent them. So I know, Jeremiah, that's not the direction you sounded like you were going. You sounded like you wanted to treat the aneurysm because you didn't want AVM treatment. But I worry that this AVM is going to continue to dysregulate her circulation and that she needs the AVM out.
Adam, how risky is it to navigate past the aneurysms to embolize those mid-temporal PCA feeders? Are you worried you could rupture the aneurysms, or the technology is pretty good?
I mean, nothing is totally safe, but I think with a good roadmap and an asleep patient, if you're careful, you can get out there and embolize those. Again, I'm not trying to cure the AVM, right? I'm just essentially placing endovascular clips on those little feeders. So I think the key here is not to be too greedy. You don't want to stick a catheter in there and then pull, against those aneurysms. You just want to make your surgery a little safer.
Jeremiah, back to you.
Yeah, so she...
oh, I'm sorry. No, I'm sorry. Let me ask Mustafa. Mustafa, what would you do? Aneurysm, AVM? You're muted.
I will convince her to have the surgery for AVM excision first, and depends on the exposure. I may need to take a look at that the aneurysm.
Basilar tip, yeah, subtemporal. You're there anyway, right?
I am there anyway, and I can, if I can slam the clip, that's fine. If not, we can watch or coil. But I agree with Adam and the rest of the panelists. If you resect these high volume AVMs, aneurysm will remain same or regress.
Okay, Jeremiah.
Yeah, thank you guys. I agree with all of your comments. In this particular patient, it had grown, it almost doubled in 1 year in size, and she did not want surgery at the exact moment, still considering surgery, and I had certainly recommended probably embolization of the PCA feeders and surgery was the plan, but for a variety of reasons with her family, she did not want that. So as a stopgap measure, we decided to treat this aneurysm. And the thing that is a little bit hard to see on these 3Ds, you can pick it up on a couple of the 2D images here, including this one, is that she has a very nice PCOM here between her carotid on the right side of the same side of the aneurysm. So we felt like it was a pretty safe route for embolization. You can see the tail of it here to bring a catheter through PCOM, which would be much more in the vector of this aneurysm, and treat this while she's preparing her family to undergo more definitive treatment of the AVM. So this is just the lateral view of her right carotid, showing roughly the trajectory. You can see the catheter here coming across PCOM and the wire starting to move toward the aneurysm. Brought a balloon up just in case we needed it through the basilar. So this is this catheter here, the two tips of the balloon. We ended up not needing it. And successfully coiled. You can see PCOM here, and then coiling that, particularly that more dysmorphic tip of the aneurysm that stood out, leaving this base. And that at the time of the procedure, we actually saw what looked like a small perforator from the base, probably why the aneurysm formed to begin with. And then nice coiling here. Again, this was meant to be a stopgap measure, and you can see a really good picture of this dysmorphic perforator from the posterior aspect of the basilar, P1 that goes and feeds the AVM. Some of these large perforators are just not going to be embolizable, but very complex vasculature coming from her proximal PCA there. So she did well, and we coiled this right before Christmas, actually more like October. And we're planning to have treatment after the New Year's, and which COVID then hit. So now her children have gotten older. They're 9, 7, 5, and 3. And the question is, she's still very hesitant to do anything which may cause her to be incapacitated or have to go undergo rehab for any significant period of time. So in my mind, the question is embolization and resection, which is, of course, a very good way to go for definitive treatment, particularly with all the perforating aneurysms, or to do something like stage radiation, and then potentially operating on it when her children are a little older. So that's kind of where we are now with her case, but interesting decision making to make on some of these patients.
Roberto, what would you tell the patient if she's your patient with that entire family social, elements that Jeremiah is giving us? Are you muted? I'm not sure if you're muted. Yeah, you're muted.
Yes, I'm muted now. I'm unmuted. No, I would advise, it's on the right side, and it'd be a difficult operation. I think that, I would advise her strongly to have it embolized. Again, I would embolize those medial temporal feeders that I think it'd be hard to get to without, we keep talking about the left side and the vein of Labé and subtemporal retraction on the left side being dangerous because of vein of Labé, but I can tell you that I've had problems with the vein of Labé on the right side, and the patients have been very incapacitated, because they've had a deep, going more superiorly temporal infarct. So it can be very incapacitating even on the right side. So I would embolize the deep temporal feeders, those mid-temporal feeders from the PCA, and then recommend resection of the AVM. The aneurysms, I probably would watch them, and I think there is a very good chance that they would regress once AVM is removed. But you've already done a great job with that. That was brilliant to come through the posterior communicating artery, Jeremiah.
Thank you.
Yeah, because I was thinking, well, coming antegrade on the P1, how are you going to turn around? But that was
two turns, anterior and median.
That was just brilliant. But I would recommend that she have it done. She's a young lady. She likes to exercise. She likes to run. And her mother died of an AVM. I don't know if that makes any difference, but it would make a difference in terms of her understanding the danger of these things. So.
Anybody else on the panel would like to comment on the case before we open it up for questions from the audience that Carolina Benjamin will help us navigate through?
Yeah, Jeremiah, I think we had a sort of similar patient, similar sort of social considerations and functional considerations. And, you know, I think I just want to touch on something that Dr. Arthur said. And, you know, he had mentioned sort of using embolization as sort of an endovascular clips for the deep feeders. And I think that a lot of the literature that's been written discussing the morbidity of preoperative embolization is with embolization with the intention of nidal penetration. And I think that that's where a lot of that morbidity happens, when you push too much onyx and you get some into the vein, or as Dr. Heros had mentioned, you're pushing, and then you get 90% of it, and you don't get all of it. And I think that also speaks to what Dr. Heros said about having, you know, a neurosurgeon heavily involved, if not doing the preoperative embolization, because you don't necessarily need to get nidal penetration if you're planning to go to surgery. And if you're planning to use it as an adjunct, I think you can use it, as Dr. Arthur said, as an endovascular clip for these deep feeders to sort of alleviate some of that trouble.
Jeremiah, can you stop sharing your slides so we can all see each other? That'd be great. Thank you.
I agree with you know, everything that Stefan just said. You know, I think most of the AVM embolizations that we do, either before I take a AVM to surgery or before Dr. Morcos or someone else takes a AVM to surgery, a lot of times we're just doing a point pedicle takedown of a very deep feeder without any nidal penetration. And that's where I think, you know, some of the literature is not as relevant. When you look at the complication rates with embolization reported in the literature, they're actually really quite reasonable and often quite high. And a lot of times that's, as Stefan was saying, because they're penetrating into the AVM. And I think that's where a lot of the complications occur. Versus if you're just coiling off a feeding branch, that usually takes, you know, a couple minutes, extremely safe, very easy to do, versus some of the really challenging embolizations where people are trying to fill up the AVM. And I agree, again, that's where I think having neurosurgical input is tremendous, because you really start understanding what's going to make your surgery easier, faster, safer, less likely to need a blood transfusion. So those are the four things that I'm thinking about.
Maybe I could just
make a comment about that problem of embolization. And I have, as I told you, the experience with 3 patients that bled after embolization because the endovascular, he was a neuroradiologist that did the embolization, very, very good technically, but he really wanted to occlude these AVMs. And then if the point is that he would call me and say, and I preserve the vein or a vein. So the issue is that even if you have a vein preserved, the architecture of AVMs is such that you could, during the embolization, you could occlude the outflow of part of the AVM that doesn't necessarily communicate with that vein that was left preserved. And that's where you get the hemorrhage postoperatively. So it's subtotal embolization, I think, is very dangerous. If you can do total embolization, wonderful, but you got to aim at total embolization or not, and then just do selective embolization according to what is needed for surgery. But this idea that, well, I go as far as I can and then quit is not good, because there are compartments of the AVM. You occlude the outflow to one compartment and leaving the vein patent in another compartment of the AVM doesn't help.
You know, I think that's a really good point. AVMs are complex, and I don't feel smart enough that I always understand how they're going to compartmentalize. So I've had the experience both in the operating room and with embolization of being surprised by the effects of what I've done. I'll never forget an AVM I did years ago where, while I was taking down one wall, it ruptured on the other side of the AVM. And I swear I never took a vein. It just had compartmentalized in such a way that all of a sudden And I think Atul mentioned this. You can get bleeding that surprises you. So subtotal embolization is not something that is predictably safe. It can be unpredictable.
I was wondering maybe if I could just poll the panel for the guys that are doing the pre-op embolization or embolization of AVMs. Is anybody doing them awake or with provocative testing in some way prior to embolizing?
You only have 2 people right now on the panel who can answer you. Bob
right.
left.
Not unless it's an extraordinary case and you're something very eloquent. Yeah.
I used to on all of them, and now I don't anymore. There's no scientific evidence for that, but I guess I feel like angiography's gotten better to the point where I can really see what's cortical or what's feeding brain and what isn't, and maybe I've become cavalier. But I don't think that's a settled question in my mind.
I'd like to make a technical point. I don't know if it was really covered, but particularly for the young people in the audience, in one mistake, I think you could tell a really great microsurgeon from another is the use of bipolar on the surface of the AVM. There are some people who like bipolar, their way spiraling around the AVM, and that is a terrible mistake, even though you don't lose the main vein. And this is what Nobuo Hashimoto showed us in his beautiful cast specimen. Those venules around the AVM, the nidus, can be occluded, effectively occluding the main, as if you had occluded the main vein before you remove the AVM. And that's often the cause of intra-op disaster. So the meticulous technique of, like, for example, Mustafa was showing, is very important to preserve venous outflow at a more proximal level than the main vein is. Hashimoto's loops, we kind of got to call them.
I completely agree, Dr. Morcos. First, Adam is very right saying that it's, with my current understanding, I cannot know by just looking at the MRI, angio, or at surgery, even you are looking at the AVM, I cannot get the whole picture of it. If I dissect without disturbing the venous outflow, and the venous outflow is not just the vein, draining veins you see in the angiograms. There are so many small veins around the AVM. And if you disturb them, you are running into trouble. First, you understand the normal, then the pathological anatomy.
Okay, I'm going to ask my partner, Dr. Benjamin, to navigate us through the Q&As, and you're in charge, Carolina.
Wow, fantastic talks. Thank you. And great cases. So we have a few questions here from the audience. For Dr. Arthur, we have Chizor asking, what if the preoperative embolization accidentally involves other important key vessels apart from the targeted feeders causing new deficits? How feasible is that to correct at surgery, or have you experienced this?
I don't think that's very feasible to correct at surgery. So I think what I'm hearing is an embolic stroke as a complication of the embolization. And unfortunately, in that case, the cat is out of the bag, the horse is out of the barn. Perhaps one Mustafa or somebody can tell you that they can go in and do an embolectomy and remove the onyx from the vessel, but that's beyond me.
Endovascular embolectomy of onyx.
I guess a follow-up question to that, then what would you say about the timing of surgery after embolization? The sooner the better?
You know, that's an interesting question. I don't know the answer. De Oliveira once told me that he hated going to the OR directly after embolization because he thought that the embolization caused a growth or relaxation of the other feeders. So it was always for him embolization, several weeks, and then surgery. And then other people have the opposite idea. You know, they want to do an embolization and go immediately to the OR. I have done more embolization and then OR the next day than waiting in between. I have done for large AVMs some staged embolizations where we do an embolization, wait a few weeks, do another one. I do sort of subscribe to the tenet that you don't want to take more than 30 to 40% of an AVM in one embolization because of this issue of potentially changing the flow in frightening ways. But again, I like to be scientific. so much in vascular neurosurgery seems to degrade to, well, I'm just going to say what I think, and then we all say what we think. And I don't know the answer about the timing of embolization of surgery and whether it's different in different AVMs or not. So maybe the rest of the panel can educate me.
Yeah, I can tell you, it depends on the reason you do the embolization. If you're doing the embolization in the rare cases where you are afraid, like that case I show with that very high flow Vermian AVM that I had the problem with the deep venous thrombosis, if that patient should have had embolization and probably slowly, you know, not to try to, as you say, to occlude maybe 30% of the AVM and then 30% of the flow to the AVM and then 30% later on. So if you're doing it to reduce the flow to prevent problems with perfusion breakthrough, thrombosis of veins and so forth, I think you got to go in stages and do it slowly. But 80–90% of embolizations that I did were preoperative embolizations just to selectively occlude deep inaccessible feeders, and for that is no need to wait. You can do it the day before and then do the surgery the day after. There is no need at all to wait. One of the problems with waiting of embolization that I've had, you know, I'm convinced that the patients that develop dural feeders to an AVM or even transcranial feeders of the AVM is because the arachnoid barrier has been broken between the AVM and the dura. And of course, that can happen as a result of a hemorrhage. So a patient that have bled in the past, you can have this problem with dural feeders and even transcranial feeders. It can happen, but it can happen also with embolization, in my experience. Patients that have been embolized at some point in the past, and you're going to operate on the embolization, depending the material you put it. Practically with every material, you get an inflammatory reaction that then produces a problem with dural feeders to the AVM, which at times presents a real problem.
Jack, can I make a smallish point?
Please do.
The issue is about normal perfusion pressure breakthrough. That is the issue which is under discussion and which is, you know, under discussion for a long time. My feeling is, you see, I have done several large and several high flow AVMs. My feeling is normal perfusion pressure breakthrough as a phenomena may not be real. What the bleeding happens in the postoperative period is more often due to leaving behind some small AVM rather than having a perfusion pressure phenomena. So more important is to identify all kinds of small and big vessels and remove the AVM completely, and that is a trick. It is not easy to remove the AVM completely. You know, even experienced surgeons may have a problem and they find some little bit residue here, little bit residue here. And if you leave a residue, the problem of bleeding postoperatively is, and that you can sometimes label as normal perfusion pressure. That is my feeling.
Atul, you're in good company. Yazargil, after his 414 AVMs, said he doesn't believe in it. Doesn't believe that perfusion breakthrough exists, and that exactly he made your point many years ago. Of course, remains a bit controversial among people who do it, but Carolina, take us down the questions.
All right, Dr. Baskaya, how reliable is it to use just the discoloration of the nidus following application of a temporary clip to distinguish the feeders from en passant arteries?
I mean, that depends on the timing of when you are doing that. If it is late in the dissection and you are putting temporary clip and your AVM may get discolored and get more blue, or you may get softer. So you just depends on the size, type of feeder. Small side feeders won't make big difference. Big feeders will make major difference.
And of course, ICG with that trick is very helpful.
Well, you can do ICG, you can do Doppler, you can check many things to make sure that's a true feeder, not the artery is supplying the normal brain. But the best thing is after temporal clipping, following the course of that artery and making sure it enters the nidus and taking at the next to the nidus.
Okay, one question I think for all of the panelists. Do you think preoperative embolization is perhaps helpful in the less experienced surgeons? I guess their point saying, you know, we're aware that master surgeons can resect these AVMs without it, but do you think this is something that perhaps less experienced surgeons should use, especially as they, in the beginning of their career?
That's a tough question.
It's a tough question, but it
politically
actually goes-
sensitive question. And you know, this goes back, not related directly to this question, but a comment that Jack Morcos made is very important, and all of us face that. And how often do we get a call from, you know, from somebody who you don't know very well, you don't know how much experience they have, and they send you a case and they say, now what would you do, Dr. Baskaya? What would you do, Dr. Morcos? And you got to be very careful, because as Jack pointed out, what you would do yourself, a very experienced surgeon, may be very different than what the person that is asking the question should do, depending on their experience. And, you know, AVM surgery is elective surgery. And unfortunately, nowadays, there isn't the luxury to that some of us had. When I started doing AVM surgery, there were only a few people doing them, so that I just had to learn this and hurt people as I went. But nowadays, it's totally elective surgery. You have to be very careful, and very frequently we have to give the advice that we have to give is a very politically difficult advice, and is to tell the patient that is asking the other surgeon that is asking us to say, you know, shouldn't you refer that AVM to somebody else who has more experience? That's a very difficult advice to give, but it could be very dangerous to give advice based on what you, with your experience, would do, as opposed to what the person asking you the question should do.
Yeah, can I turn this question to Atul? Atul, you've trained a number of, you know, younger neurosurgeons. Is it okay to tell them it's okay the first year or two in your practice, go ahead and embolize those deep feeders. Don't do what you've seen me, Atul, Goel do, because you know that they will probably have an easier time, you know, climbing the curve of competency. Do you think that's okay?
Jack, as I mentioned, AVM surgery is the pinnacle, is the ultimate. It is the last chapter of neurosurgery. And unless and until the younger fellow thinks that he is senior now enough, you know, it is not a game that you can ask, as Professor Roberto said, that you cannot just let somebody try his game. You cannot say, okay, you try, don't worry, I am standing by your side and I am there to train you and I am there to. You have to have, one is absolute confidence in what you are going to do.
How you have to have start? They have to start in
they have to start, of course. But you know, you have to give to that person who will be able to handle without any preoperative embolization, which may not be an absolute, you know, does not reduce the extent of bleeding. If it was reducing the extent of bleeding, why I will not use it? Tell me. If suppose preoperative embolization helps me, I told you that we have a fantastic interventional department. I am not a crazy person not to use the help. If somebody says, okay, you go in, I will reduce your bleeding. Why not? I don't think it does that to me. I don't think whilst dissection of AVM embolization helps me in reducing the bleeding, the flow is reduced. You know, you will ask me when I will do embolization. You should have asked me. You see, preoperative embolization, there are some cases where I say no, you do not, I cannot operate. There is no way I can operate without having a very high risk to your life and to your other things. In that situation, I may seek the help of interventional radiologists to take care of some intranidal aneurysms, take care of some aneurysm, like in the case which was shown earlier, to take care of some feeding vessel aneurysms, and to put some, little bit inside the nidus, some kind of emboli. I may seek the help of in those situations rather than pre-surgery embolization. And I don't think it really helps the surgeon.
Okay. Carolina, go down your list.
Okay. We have one. How often and in what cases do you guys operate on high-grade AVM? I think that was touched upon, but perhaps
that was pretty much touched upon by both speakers, but go ahead, guys.
Do you have any hard and fast rules?
Individual case, desperate cases, you really have to do something, and those cases usually embolization has a role. And I'm not saying I will never operate in grade 4s or 5s. In certain cases, you can operate. How often, I don't know. I don't remember my numbers.
Adam? Same thing.
These last two questions touch on the delicate interface between surgical ambition and surgical ego. And we all have to live with our conscience, and we all have our graveyard that we walk through. I worry that because of the culture of neurosurgery, sometimes we're imputing that all high-grade AVM should be operated on, and I just, that's not supported by the evidence. So the majority of high-grade AVMs, I think, really should be managed conservatively. I'm not dogmatic about that, but when I moved to Memphis, there's a senior surgeon here, is a phenomenal guy, a fantastic surgeon named Morris Ray. And after training in Utah with Bill Caldwell, he was very aggressive about operating on grade 4 and 5 AVMs. Dr. Ray would come and put a film up in my clinic and say, what do you think about this AVM? And I'd start talking about how I was going to operate on it. And he'd say, yeah, that film is 10 years old. They've never had a rupture and they're fine. And he did that to me multiple times. So I do think that with age and experience comes wisdom and the ability to hold back and say the natural history of the disease is better than surgery. And the preponderance of evidence is that with the majority of high-grade AVMs, reassurance and monitoring over time really is the best therapy.
Adam, I completely echo what you said, completely and entirely. You know what? AVM surgery is not easy. AVM, those who do, they know that AVM surgery can be a disaster for the surgeon and for the patient. Which AVM will be disaster, which will not be disaster is an absolute key. And that key is with the surgeon. That key is with you and with the one who is going to operate. He should be, there is no place for ego. There is no place for standing tall. You have to work with the AVM. You have to study that AVM diligently over the night, over the weekend, over the week, and decide these are the weak points of the AVM. This is the way I can do it. This is the way I can do it. This is the point I can handle. This is the way I will do it. The moment you feel that, no, it is going beyond me, you should have the courage to say, yes, there is no way I can harm the person. Because if you harm the person, it is a disaster. You can imagine a person becoming hemiplegic and he's not going to die because these are not malignant tumors. He's going to live with that deficit for the rest of his life, and you should know it. And that is the key. I think that is the key to AVM treatment in general and surgery in particular.
I'm going to ask a question to the two youngest on the panel, Stefan and Jeremiah. Just maybe give a sense to the audience. I'm assuming the audience is mostly young people, aspiring neurosurgeons or early neurosurgeons. But what keeps you from sleeping well at night when you're thinking about an AVM you're going to manage? Is it just, I don't want to put words in your mouth. I'm just curious, in your first few years of practice, what is it that you're worried about in approaching an AVM? I don't know if my question makes any sense, but hopefully it does. Jeremiah, since you were my resident. You go first.
Yeah, for me, it's deep feeders that you can't control. This very most deep portion, in my experience, is that it's the hardest to control the bleeding, these very fine deep feeders. And you can spend hours trying to get them at the very end when there's a mass between you and them. That and just the eloquence issue. You really feel for the patients, you want them to come out intact, as kind of Dr. Heros alluded to. That's the standard that we face now, is that people need to come in and come out and roughly unchanged. And those are the things that keep you up.
Stefan?
Yeah, I would echo both of those things, and that's, I mean, that is the reason why I presented the case I did, is because, there's all these sort of, there's the eloquence factor, there's the deep feeders that are going to be difficult to get to that potentially are amenable to embolization. And, there's, as with Jeremiah's case, the whole social component of, a young, highly functional woman, mother, that really can't afford to become maimed in any way. And so I think, that's certainly the things that keep me up.
Carolina, have we not covered any questions?
Yeah, just a couple more.
Okay.
We actually, staying with you guys, would you actually ever consider intraoperative embolization of deep feeders? And Bobby, maybe you can comment on this too.
I can't think for an AVM of any times that we've done intraoperative embolization. I think for occasionally for fistulas where you're talking about a really difficult, an area that can't be reached with, easily with surgery, and you can't easily navigate through severely tortuous anatomy. Sometimes we consider it, but at least personally, I can't think of a time we did it for an AVM.
Yeah, I haven't done any intraoperative embolization for an AVM, but I do try to do them in the hybrid room in order to do an angio at the end to be confident that there's no residual and things like that.
Be on the lookout for a publication. I don't know when exactly, but our good friend Fadi Sherbel has had some interesting thought about intraoperative transvenous embolization of AVM. We had his usual February meeting, and anyway, I'm not going to say.
Jack, I want to ask one question to Adam. Yeah. Adam, what do you think of venous embolization? For AVM to block the veins. What is your thought on that? There is recently some discussion on this subject, like you should come by venous route, and if you block the veins, ultimately the whole AVM might disappear. What is your thought on that?
Yeah, it's very interesting, isn't it? Going to the endovascular meetings, there's a real swell in Europe, particularly, of emphasizing curative embolization and transvenous routes to do it. I have not done that very much. I don't think I've ever treated an AVM transvenously, a true intracranial AVM. I've done fistula work transvenously, but not real AVM. So at this point, I'm a skeptical observer and an audience member on that topic. I think it's very interesting. There are bright people who are touting it, but I'm not convinced. How's that?
Yeah. Carolina, try to finish up the question because it's 7:30. What's the last thing?
That's pretty much it. That's
pretty much it.
Somebody was asking about, the role of radiosurgery in AVMs, and I sort of answered it to them directly just because.
Can I end up with a very sad question? Does anybody...
Roberto, you're not on video. We cannot see you unless that's what you intend to happen.
Can anybody guess what is by far and away, and I mean by really far and away, the most common treatment of cerebral AVMs in this country today? I don't know about India or Europe, but I know in this country for sure. The most common form of treatment.
It's endovascular embolization, right?
Is partial embolization.
Yeah, I know.
Partial embolization. The number of AVMs that are treated by just embolizing a little bit in here, a little bit in there, a little bit and then telling the patient, oh, I've reduced the flow of your AVM by at least 40, 50%, with the implication that, oh, that reduces the risk of hemorrhage by 50%. And the reason I mentioned that this is sad is because there's absolutely no evidence that partial embolization as a definitive treatment does anything, number one. Number two, there's plenty of evidence that it's dangerous. So it's incredible that a treatment that is not proven to be beneficial, it has proven to be dangerous, is the most common treatment nowadays for cerebral AVM. So you have to go no farther than look at the Aruba study. That's representative of what by far, that was the most common form of treatment, partial embolization, and then say goodbye. Anyhow, I didn't mean to end up with a sad thought, but
no, that's okay.
Same true for the radiosurgery too. Partial treating components of the AVM.
Also very common.
Well, on this was tremendous panel. Thank you, Adam. Thank you, Mustafa. Thank you, all the panelists. Thank you for the audience. We had a huge number, in addition to the numbers you can't see, who are on the live YouTube channel, in addition to the people who are here with us.
How many people you think?
Well, we had here at least 250, plus whatever was. We will know in a couple of days when I'll send out on my Twitter.
Oh, that's interesting.
And I will say if they preferred Mustafa or Adam. I'll let you know all who's the real winner.
The poll.
There is no winner.
Indeed, everybody's a winner because of this.
We learn a lot. Thank you very much.
Good
There's
evening,
no winning
everybody.
neurosurgery, just variable degrees of losing. But thanks for the opportunity.
Thank
Gotta go
you.
back to work now.
Stay
Good
safe,
morning.
everybody.
Atul,
Good
thank you
morning.
for joining. Thank you.
5 a.m. here, 5 a.m.
Time to go to sleep.
Good morning, Atul.
Yeah. Good morning, good evening. Have a good dinner. Bye-bye. Bye-bye to all of you.
Bye.
Bye-bye. Bye-bye.
Thanks, guys.